Okay, and I'd like to welcome Karen Middlecoop and Richard White up for this award. I think. And so Karen is the Program Secretary of the Union HIV section, and Professor Richard White is from the London School of Health and Tropical Medicine. Thank you.
TB HIV Research Leadership Prize was established in 2016 through a global partnership between the TB Centre in London, the Desmond Tutu HIV Centre in Cape Town, and the Union. It acknowledges young researchers under 40 years of age who are conducting promising work focused on reducing the disease burden of TB and HIV/AIDS in Africa. And I'm so honoured to present the first award of the Stephen Lawn Award that honours a colleague and a friend. So we want to congratulate this year's winner, Dr. Leonardo Martinez, for his research and leadership that embodies the knowledge, commitment, and the spirit portrayed by Stephen Lawn. Dr. Martinez is a postdoctoral research fellow at Stanford University's School of Medicine. He received his Masters of Public Health from Tulane University School of Public Health and Tropical Medicine in 2012, and his PhD in epidemiology from the University of Georgia in 2017. His research, which has been conducted primarily in Uganda, covers a range of interests, including the epidemiology of tuberculosis, with a focus on the location of occurrence for person-to-person transmission, and applying meaningful, effective interventions and policy recommendations to mitigate the spread of TB in economically impoverished settings. Please join me in welcoming Dr. Martinez to the stage.
So it's given me great honour to present Leonardo with this prize, and on behalf of the London School. Steve Lawn was a much loved and very well respected colleague, and it gives me great honour to present you with this prize. Thank you. And can I also present a card from his wife, Joy Lawn?
Thank you. Thank you very much. I didn't get a chance to meet Stephen Lawn, but I've read all his work. He's an amazing researcher. But more than that, since I won this award, I've been talking to everyone I know about him, and he seems, everyone says that he's also an amazing human. So it's really a great honor to get this, and I want to thank the Desmond Tutu Center and the Union and the presenters as well. Thanks so much.
Thank you very much for that extraordinary award on behalf of Stephen Lawn. We will now start our session, the TB, HIV, and diabetes letter breaker session. And my name is Haile Jesus Getaun, and I work with the WHO, and I co-chair this session with my colleague Amy Bloom from USAID. The session will have 6 presentations, and in TBA and diabetes and TB HIV. And the first presentation will be on diabetes, increases mortality during tuberculosis treatment, and metformin use reverse this effect. And the presenter is Nicholas Degner, who is a second-year resident in internal medicine at Stanford University. Nicholas.
As stated, the title of my talk is Diabetes Increases Mortality During Tuberculosis Treatment, and Metformin Use Reverses This Effect. This work was done with Drs. Golub and Karakoussis at Hopkins and Dr. Wong at the National Taiwan University Hospital. So first, a little background. Patients, as you all know, with diabetes are at increased risk for developing active TB, and once they do, they experience worse treatment outcomes. However, the precise impact of diabetes on TB remains unknown. That is, diabetes is often associated with older age, obesity, multiple comorbidities, and poor treatment adherence, all of which have been shown to influence TB treatment outcomes. So the first aim of our study was to better assess the effect of diabetes on mortality during tuberculosis treatment and to look at 2-month TB sputum culture conversion. And then in turn, we also wanted to look at potential solutions to this problem. And so there's been a lot of attention recently on turning to host-directed therapy for tuberculosis, and in particular metformin. Metformin, as we all know, is an anti-diabetic drug, but has also been shown to activate AMPK, which is a regulator of autophagy, an important process in the immune control of tuberculosis. And so in an excellent study by Singhal and colleagues in Singapore, they demonstrated that in a translational study that metformin inhibited the growth of MTB in macrophages in cellular culture. It reduced the lung bacillary load in a mouse model of TB, and in turn reduced the TB-induced pathology and inflammatory gene activation, and then in turn decreased the TB severity and improved clinical outcomes. So with these promising results, we wanted to in turn evaluate the effect of metformin use on survival during tuberculosis treatment. So to do this, we conducted a retrospective cohort study, including all patients aged 13 years and older who presented with culture-confirmed drug-susceptible pulmonary tuberculosis. And these are patients that underwent treatment at National Taiwan University Hospital in Taipei from the years 2000 to 2013. So we included all comers. There were no exclusion criteria. And as stated before, the outcomes were both two-month culture conversion and all-cause mortality during tuberculosis treatment. So taking a look at the cohort, in total there were 2,416 patients in this cohort that underwent treatment from 2000 to 2013. And as you can see, 29% of them were diabetic. And this was based upon ICD-10 coding or 9, blood glucose levels, or being prescribed an anti-diabetic medication. And as expected, the median age of diabetic patients compared to non-diabetic patients is they're older, a larger percent were male, and they had a higher mean BMI. And you can see in general this population of tuberculosis patients was skewed male, 68%, and then among the diabetics, nearly 3/4 were male. Next, looking at their comorbidities, something we wanted to assess in relation to its effect on treatment response. You can see that, as expected, diabetics have much more chronic kidney disease, cancer, hepatitis C. They have lower rates of HIV and higher amount of tobacco use, and this is a history of tobacco use, so prior or current smoker. And then you can see they had similar rates of hepatitis B, autoimmune disease, and alcoholism. And then finally, their clinical characteristics as it relates to tuberculosis. In our study, although they did have more cavitary disease, it wasn't significant. There was the same amount of smear positivity on presentation. And when looking at TB treatment adherence, which was defined as completing 80% or greater of anti-TB medications up to the point of completion or death, there were similar rates of adherence between the two groups. So what does the raw data show? As I've seen before, the mortality among diabetic patients compared to non-diabetics is quite a bit higher, 29% versus 14%. And then looking at 2-month TB sputum culture positivity, it's also significantly higher at 24 versus 14%. But once you get out to 6 months, you see that although numbers are small, there was no significant difference, indicating that there's a delay, but ultimately results are achieved. Now, as I'd shown in the characteristics in Table 1, 2, and 3, there are a lot of differences between diabetics and non-diabetics, and so we wanted to take this into account using a logistic regression model. So here in the left column, you're looking at crude odds ratios for each of the variables, and in the right is our multivariate model with the adjusted odds ratios. And as you can see, before adjustment, diabetes is associated with increased odds of mortality. And then after adjusting for age, sex, chronic kidney disease, cancer, hepatitis C, tobacco use, cavitary disease, and treatment adherence, tuberculosis remains significantly associated with mortality during tuberculosis treatment. Now, you'll notice that BMI is included. We only had BMI data for 1,749 of the 2,416 patients, but in the model where we only included BMI, we found that increasing BMI was associated with decreasing mortality. And when you include it in this model, diabetes remains significantly associated with mortality during tuberculosis treatment. And in fact, the odds ratio is even higher at 2.02 versus 1.91. So next, the same model, but this time looking at 2-month sputum culture positivity. And you can see again, in the unadjusted and after adjustment for all of these variables, diabetes remains significantly associated with remaining 2-month culture positive at odds of 1.72. So next, looking at metformin, what we wanted to do, as I said, with our second aim was to evaluate the effect of metformin on survival. Now, since metformin is an anti-diabetic medication, we only looked at the diabetic patients. And then, because metformin is contraindicated in patients with chronic kidney disease stage 3B or higher, we excluded those patients from the analysis to eliminate potential confounding. So that was 46 patients, leaving us with 634 total patients. And so in red, you can see patients on metformin, and in blue, patients not diabetic, so diabetic patients on metformin, and in blue, diabetic patients not on metformin. And in the survival analysis, you can see that there is a significant difference in mortality between the two groups. And if you, the exact values come out to almost 31% versus 17%. So now there were significant differences between diabetic patients on metformin and diabetic patients not on metformin, and so we performed a Cox proportional hazard model to try to account for this. And so again, on the left you see crude hazard ratios, on the right adjusted. So looking at metformin use, the hazard ratio was 0.5, and then after adjusting for age, sex, chronic kidney disease, cancer, cavitary disease, and tuberculosis treatment adherence, it remains significantly associated with decreased mortality during tuberculosis treatment with a hazard ratio of 0.56. Now, we did this two ways. This is back to the table before. We wanted to look at it in two different manners. So metformin use was assessed looking at prescription records. And so in the first one, we performed what we would like to call an intention to treat analysis. That is, if a patient was on metformin during the first 30 days of tuberculosis treatment, we classified them as being on metformin throughout treatment. But in our second approach, we wanted to use documented use of metformin. So we looked at the prescription records and only classified those that in the prescription records were shown to have been on metformin throughout at least 80% of tuberculosis treatment as being on metformin throughout. And when using this classification, you can see that the difference in mortality becomes even more significant. Mortality among metformin users is near 10% versus 30% in diabetic patients not on metformin. And again, using a Cox proportional hazard model to adjust for the differences between the two groups, you can see that after adjustment, the hazard ratio is even smaller at 0.41. And then finally, we wanted to compare diabetics on metformin to non-diabetics to see how mortality compared between the two groups. And so here you see in red now are diabetics on metformin, and in blue you see non-diabetic patients. And in this Kaplan-Meier curve of survival estimates, you can see that there is no significant difference in mortality according to the chi-squared value. And indeed, if you actually adjust for the differences between the two groups using a Cox proportional hazard model, adjusting for age, sex, CKD, cancer, hepatitis C, tobacco use, cavitary disease, and treatment adherence, there is no difference in survival between diabetic patients on metformin and non-diabetic patients. Or stated another way, metformin reverses the adverse effects of diabetes on survival during TB treatment. So in conclusion, despite the advanced age and multiple comorbidities of patients with diabetes, this just strengthens the existing evidence that diabetes itself poses an increased risk of death during TB treatment and of remaining culture positive at 2 months. That is, it delays culture conversion, and diabetic patients remain infectious for longer than their non-diabetic counterparts. And then even more exciting, based on our data, it appears that metformin may, along with standard TB treatment, reverse the increased mortality associated with diabetes during TB treatment, suggesting a potential role as adjunctive TB treatment. So thank you, and I'd like to acknowledge these 2 grants that help fund the work. My amazing mentor, Dr. Karakoussis, who's been great. Our collaborators, Dr. Wong and Dr. Golub. Thank you very much.
Thank you. Thank you very much for that presentation. So we have time for questions. And there are mic. If you could line by the mic, that would be good.
Hi, Megan Murray from Harvard. So one possibility is that the metformin normalized blood sugars and that the effect that you see is due to control of hyperglycemia, and the other is that metformin is having another effect through some kind of immunological route. What's your sense for that?
Yeah, this table, I realize is a little busy, but this was, I was anticipating that, and it's interesting if you actually look at the A1Cs that were available for patients that were diabetic compared to non-diabetic, diabetic patients on metformin actually had higher hemoglobin A1Cs and fasting blood glucose. So there was no difference, and if there was a difference, it was actually poor glucose control among the metformin users. So it actually seems to indicate that the effect is independent of blood glucose control. But yeah, it's a great point. Thanks.
Yeah, Hardy Kornfeld from UMass. Great data. Do you have any information on statin use as a potential confounder in this population?
That's what we're going to look at next, actually. Yeah, but no, not yet. Yeah.
Thank you very much for the presentation. This is Lin Yan from the Union based in China. In table 7 you presented, there is a significant difference, on the treatment adherence between the diabetes group and the non-diabetes group. Of course, this is a similar, funding from our research in Guangzhou in China. My question is, the treatment adherence is not only related to diabetes, but also the way of DOT provided to the group of patients. So when you compare these factors, did you adjust the patient, compare the patient between the diabetes group and the non-diabetes group under the same way of DOT?
No, we didn't, actually. I think that in terms of, so your question is comparing patients under directly observed therapy to those not under directly observed therapy. Am I understanding that correctly?
Such as the DOT provided by the different provider. Like this group may provided by the health worker. Like that group may provided by family member or some others.
I see.
So is this the same kind of comparison or roughly just the 2 different groups?
I see. Okay. Yeah, I think we don't have that fine of data. We do know, though, that in Taiwan implemented kind of DOTS type treatment in 2006, I believe, and our data is from 2000 to 2013. So I think the closest approximation we could to that would be to look at the patients prior to 2006 compared to those after, and maybe looking at the treatment adherence differences and trying to approach it that way. But yeah, that'd be very interesting to look at.
Thank you very much.
Thank you very much. The second presentation is on feasibility and yield of routine bidirectional screening for tuberculosis and diabetes mellitus in primary health settings in Zimbabwe, and it will be presented by Dr. Shepard Machakera, who is TB-HIV Technical Officer for the Union Zimbabwe Country Office.
Good afternoon. It's not my presentation. Thank you so much for the opportunity to come here and share with you what we've been doing in scaling up the TB diabetes integrated package. So I will be presenting the feasibility and yield of routine bidirectional screening of tuberculosis and diabetes in primary health settings in Zimbabwe. To start off with, I have no conflict of interest to declare. So Zimbabwe is amongst the 30 high-burden countries for TB globally, with our epidemic being largely driven by high TB-HIV co-infection. And 82% of our cases have been successfully treated for TB in 2016, and this was a plus for the TB program. However, there's growing evidence of the linkage between TB and other non-communicable diseases like diabetes. And according to the International Diabetic Federation in 2016, 6.2% of our adult population has diabetes, and 10.4% has impaired glucose tolerance. But what is more worrying is that close to 70% of our diabetic adult patients have not been diagnosed and are not on treatment. So we received funding from the World Diabetes Foundation to pilot an intervention that looks at how do we actually screen diabetic patients for TB and link them to care, as well as screen TB patients for diabetes and link them to care. Much of this came from the collaborative framework that came out from WHO and the Union earlier on, and they had showed us that diabetes, as we have heard from the previous speaker, increases the risk of developing TB, but also leads to adverse outcomes which include failing treatment, relapse, development of drug-resistant TB, as well as death. And in our country, at this stage, we did not have a collaborative framework that addresses this twin epidemic. So our aim was to generate local evidence through implementation to assess the feasibility and yield of actually doing bidirectional screening for TB. And we randomly selected 10 pilot sites in our country that are shown here. In Harare. Harare is the capital city of Zimbabwe, and from our records, it has the highest burden overall in the country of TB. And we randomly selected 10 pilot sites where we would carry out this pilot. The implementation approach, we started off with a stakeholders meeting where we built consensus amongst the key stakeholders on what approach we are going to use. This led to the development of guidelines, SOPs, training material, information education material, as well as recording and reporting tools that would be used to capture key indicators that were of interest to us. We also trained healthcare workers from the 10 pilot facilities on how to conduct the bidirectional screening of TB and diabetes. We supported them with glucometers and strips that would be used in screening patients. And throughout implementation, we would conduct post-training supervisory support visits and on-site mentorship to ensure that we continued to have the adequate quality of work being done. We would periodically review this work in technical working groups so that we learn as we go, and if there were any areas that needed to be changed, we would address this. This is the algorithm that we were using to screen TB patients for diabetes. Basically, all diabetic patients would be screened using initially a random blood glucose that is taken using capillary blood from a finger prick. And those who had a random blood glucose above 6.1 would then go on to have a fasting blood glucose to confirm diabetes. And our working definition was a fasting blood glucose above 7 millimoles per liter, and that would be diagnostic for diabetes, and patients would be referred to the diabetic clinic, which was within the same facility, and they would also be recorded and reported. For screening diabetic patients for TB, all notified TB patients, all diabetic patients in care, would be screened using the symptomatic checklist that included asking a patient if they had any current cough, if they had night sweats, if they had unexplained fever or unexplained weight loss. And this was the same screening tool that we use amongst our HIV patients during intensified case finding. And if any patient would answer yes to any one of these questions, then they would produce one spot sputum and they would be investigated for TB using a GeneXpert. So from this implementation in the 10 facilities, we identified between April and March 2017, between April 2016 and March 2017, 1,830 TB patients. We unfortunately were not able to screen all of them because of a number of systematic issues and problems that were amongst the facilities. So we eventually screened 47% of them, and out of those, 43% of them had an elevated random blood glucose. And eventually, 7% of those who had an elevated random blood glucose who had a fasting blood glucose done had diabetes. It's interesting to note that even between these 10 facilities, there was quite a large variance in terms of the number of TB patients who eventually got screened for diabetes. And these are some of the operational issues that we're able to identify and address. This included challenges with supply chain, issues to do with staff motivation, and of taking up this new approach. Change is often always difficult to take up amongst healthcare workers, and they perceived, this new approach as an added work to what they normally do. And obviously, these were things that we have continuously improved on, and there's been a good improvement. Also, amongst these facilities who are fairly homogeneous in terms of their catchment population, there was quite a different yield in terms of the proportion of TB patients who eventually get diagnosed. I will highlight to you these two facilities. Rutsanana had 25% of all the TB patients being who were screened for diabetes, eventually being diagnosed to have diabetes, while the other one only had 3%. And these are things, again, that we are trying to tease out. Is there something that is peculiar to this catchment population that we need to address as a program? This is, again, the same results, but just to make you see the things I highlighted earlier, 43% of all the TB patients that we screened eventually had an elevated random blood glucose. This is something that we are trying to look at. Could this be explained by the transient hyperglycemia that my colleague spoke about earlier? Is this what we are seeing, or it's probably something that is just an anomaly? And regarding screening of diabetic patients for TB, again in the same period, April 2016 to March 2017, we had 862 diabetic patients attending care at our facilities, and of those we screened for TB, 17% were presumed to have TB based on that symptomatic checklist. So they either had a cough, a fever, a night sweats, and things like that. This is non-specific, we know, but again, this could actually be an indication of things happening amongst the diabetic patients. Of those that were presumed to have TB, not everyone was able to submit a sputum and have it investigated using a gene expert. And these are again operational issues regarding how sputum is collected within facilities and how it is sent to the lab. From those that we collected sputum from, 97% fortunately received their results. And of those, 1% were eventually diagnosed to have TB and diabetes comorbidity. 1% might not be interesting, but if you remember, we still have 75% of our diabetic patients not diagnosed. And this could represent overall, in absolute numbers, quite a significant burden in our TB epidemiology. So in conclusion, I think we have successfully demonstrated that it is quite feasible to screen patients, TB patients, for diabetes using simple things like random blood glucose, which are available in our context. And from those whom we screen, 7% eventually get diagnosed with TB diabetes comorbidity. And this has impact in terms of the quality of results or outcomes that we get from these patients. Not only that, we have managed to show that it is quite feasible again to screen diabetic patients for TB within routine primary healthcare settings and link them to care more importantly. And 1% of our diabetic patients turned out to have TB diabetes comorbidity, which is an emerging problem, particularly in our part of the world. To conclude, there is also need to continuously build capacity amongst healthcare workers through training, on-job mentorship, support and supervision, but also ensuring that they have the adequate supplies in terms of reagents and screening tools to ensure that they are able to carry out bidirectional screening for TB and diabetes. I want to acknowledge the Ministry of Health and particularly the National TB Program and the Epidemiology and Disease Control, which is responsible for non-communicable diseases, for supporting us in carrying out this pilot and allowing us to make use of their facilities. I acknowledge also our funders, World Diabetes Foundation, Harare City, the Union Zimbabwe and Uganda country offices, as well as my two mentors, Professor Lin Yan and Dr. Rita Dlodlo. I thank you.
Thank you. Thank you very much. So, presentation is open for questions. Please go to the mic.
Thank you. You mentioned that your patients with diabetes were taken care at the same clinics. Do you have concerns about transmission of TB to patients with diabetes who don't have TB? In Mexico, we have seen this situation. Do you have any comments?
Yeah, maybe just to bring into context the way our health system is structured. When I talk of the same clinic, I mean the same facility. So it is the same facility, and there's a diabetic clinic and there's a TB clinic. And we have experience with infection control through our implementation of one-stop shop integrated TB and HIV care. And all our facilities have adequate infection control measures in place, which makes us not worry much about issues of infection.
Hi, thanks for the presentation.
Can
My
identify
question.
yourself?
Sorry?
Identify yourself.
Hi, my name is Avinash. I work with the WHO Global TB Program in Geneva. So the question is, did you look at the rates of TB among the general outpatients compared to the ones in the diabetic clinic? Do you see them comparable or more?
Are you asking if our prevalence of diabetes within our cohort is...
No, I'm asking, this is health center-based activity. and you these are diabetic. The data you presented is probably from the diabetic clinics. I'm asking, are these rates more than the general outpatients that you have in those health facilities?
No, we haven't done that comparison.
Okay. So that concludes this presentation. Thank you. Thank you very much.
Thank you.
So our third presentation is on a rise in TB mortality where people who use drugs and commercial sex work coexist. A retrospective cohort study in a rural county in Kenya. And the presenter is Dr. Osman Abdullah, who is an pneumococcal disease expert from Kenya. Osman.
Good afternoon. First of all, I'd like to thank the union for giving me this opportunity to present this work, and also appreciate you all for coming for this session. So my talk will be a little bit different from the previous two speakers in the sense that I'm going to present to you a programmatic, routinely collected data, and not data that is for any specific study. So these are data collected through electronic TB register for a period of 4 years, and I'm going to, so we are applying, instead of the study driven by any objective at the beginning, it is driven by a need that comes from the county TB control program. So first of all, the study setting is in Kilifi, Kenya, one of the East African countries, and Kilifi, as you can see, is situated along the, Kilifi is situated here along the coastal part of the country, along the Indian Ocean, and this area enjoys a high number of tourists, both national and international, and for that reason, the economy of this area largely benefits from the tourist industry boom. But that comes with also a price, that there is a high number of commercial sex workers around this area. And secondly, this area is also unique in the sense that it is in the drug trafficking route of the East African port of Mombasa, and for that reason there is a high number of drug use within this population. And it has been well documented that commercial sex workers and people who inject drugs have high rates of HIV infection, and we also hypothesize that this group have also high rates of TB infection. So just to get onto my talk, as a way of background, according to the prevalence, TB prevalence study in Kenya, which was, whose finding was made public this year, and the study ended sometime late last year, the prevalence of TB in Kenya is estimated to be about 588 per 100,000. And this is about 2.5 times higher than was originally estimated by WHO. And about 40% of all the cases went undetected and untreated, according to this prevalence survey. And secondly, the rising, one of the review meetings in Kenya for 7 counties within the country flagged out Kilifi as one area with a rising mortality within a context of declining TB case notification. And we didn't know the reason for this. And again, just to reiterate that Kilifi is a home to some of the key populations, including men who have sex with men, commercial sex workers, and people who inject drugs. This could be a key population that will be driving some of these epidemics of HIV and TB. In one study which was conducted a few years ago, 44% of all the new infections or HIV infections resulted from the above 3 key populations. We don't have, unfortunately, data for TB, but we hypothesize that it could follow the similar pattern. So let's look briefly at the HIV prevalence among this key population. The prevalence of HIV among the MSMs, or men who have sex with men, is about 3 times that of the national average. And in Kilifi, 1 in every 2 women are HIV positive. I mean, 1 in every 2 women who are commercial sex workers are HIV positive. And people who inject drugs within this population have about 3 times higher risk of HIV infection compared to the national average of 5.6%. And looking at that, we suspect that there could be high rates of TB infection also within this population, even though we don't have data to show that. Now, having given that background information about what we know in Kilifi as a way of background, this analysis is aimed at describing the clinical and demographic factors associated with the rising mortality among people undergoing TB treatment within Kilifi County in Kenya. Notice that I've put rising mortality in quotes, because first we needed to establish indeed, as it has been flagged out in the county review meeting, that there is rising mortality. And secondly, if that is so, then what are the factors associated with this rising mortality? And to do this, we performed a 4-year retrospective cohort analysis of electronic TB surveillance data in Kilifi County using survival analysis censored at 9 months or time of death or loss to follow-up. And we we analyzed risk factors for mortality using Cox proportional regression analysis. And within a period of 4 years, between 2012 and 2015, over 9,000 TB cases were started on treatment, of whom about 3% had missing outcome data and therefore were excluded from this analysis. And that leaves us with about 8,800 TB cases to be included in this analysis. This population has about 30% of HIV co-infection. And of these 8,800, 86% completed treatment and 14% did not. That's slightly over 1,000. And of this, 470 deaths were recorded within this period of 4 years. And in the subsequent slide, I'm going to zoom into these 470 deaths to look at which point exactly during treatment does most of the deaths occur, what is the pattern in terms of case fatality ratio within these 4 years, and then what are the associated risk factors for mortality within this group. So first, when does most deaths occur during this treatment follow-up? And you can see that over 50% of the deaths occurred within the first 2 months of treatment, and over 70% within the first 3 months of treatment. And how does the overall notification, remember initially I said that while notification is going down, mortality seems to be going up. And the question is, how does overall mortality therefore compare with the case fatality ratio that I've just mentioned about? This graph has got 2 y-axes. On the left side, we've got the number of cases notified, the absolute number, and on the right side of the y-axis is the case fatality ratio. And the 2 lines here show the blue one is for all notified cases within the 4-year period, while the red one is case fatality ratio over the same period. And you can see that while the number of cases gradually declined during these 4 years, the case fatality ratio gradually went up during the same period. And secondly, in the next slide, the y-axis again has got I've got 2 y-axes. So what I've done here is I just disaggregated the previous slide by HIV status for case fatality ratios. And the overall notification, however, remains the same. And you can see that while the overall notification again shows the same pattern, so the red bars is for case fatality ratio for HIV infected individuals, while the blue bars or the blue line is for HIV negative case fatality ratio. So as you can see, while the case fatality ratio for HIV negative individuals was almost flat during this 4-year period, that of HIV case fatality ratio for HIV infected individuals gradually increased during this period. And our trend analysis for this increase showed borderline significance. And what are other factors, therefore, associated with TB mortality apart from HIV? And the first one is age. And mortality increased significantly with age, with those above 45, 45 and above, having the highest risk of mortality compared to younger age groups. Unfortunately, I mean, this could be as a result of comorbidities, including diabetes, but unfortunately in the electronic surveillance database, we do not have data for diabetes, which is a big missed opportunity, and we could not show this, but we suspect so. Females had 20% lower risk of death compared to the males, and patients who had TB diagnosis confirmed with X-ray had 60% higher risk of death compared to those who are diagnosed by other means. And as I said earlier, again, HIV-infected individuals had 3 times higher risk of death compared to HIV-negative individuals. And among those who are HIV positive, those on ARVs had about 40% lower risk of death, and those on cotrimoxazole had about 60% lower risk of death. And for BMI, compared to the normal BMI, both lower and higher BMIs were associated with increased risk of mortality. And in summary, since, as we've just seen, most deaths occurred within the first 2-3 months, that suggests late presentation for treatment and or diagnosis, which also suggests that probably these patients are presenting with more advanced form of disease, therefore exposing them to high risk of death. HIV being the main factor driving the increase in mortality, and ARTA and cotrimoxazole being associated with decreased mortality, early detection and treatment, therefore, among HIV-infected individuals is highly recommended. And in one survey, small survey, which was done in HIV and TB clinics, it was found that while nearly all the TB cases were screened for HIV, only 49% of the children and 31% of the adults in the HIV clinics were screened for TB. And as what I've just said, this is a big missed opportunity based on the risk of death as a result of HIV co-infection. And finally, TB, people living with HIV only had, according to this survey, 58% of the adults and 49% of children eligible received isoniazid prophylaxis. And finally, TB, HIV public health intervention programs targeting key populations in Kilifi, especially MSMs, sex workers, and people who inject drugs, is limited and is strongly recommended. Thank you very much.
Thank you. Thank you very much.
Marianne, but I want to make sure we keep on so that our other speakers have an opportunity. Our next speaker is Dr. Sugata Mukhopadhyay. I hope I said that right. Who is going to speak on ADPP Mozambique strategies to track and support index HIV cases and their contacts through community-based interventions that have been protecting PLHIV against TB in Mozambique. Sugata has more than 25 years experience in HIV, TB, polio, and NCDs like diabetes. He is presently working with the ADPP NGO in Mozambique, providing technical support to its projects. And he will be the next speaker. Thank you.
Thank you so much for this opportunity, and I am also thankful to my organization ADPP for giving me this opportunity to presenting this work of ADPP. I am just 4 months old in this organization, and I am really thankful to Mario, who is actually the actual principal author of this presentation, Helen, Joaquin, with whom I work with ADPP. I am Shugato. I am from India, and presently I am working with this organization in Mozambique. So in the next 8 to 10 minutes, I don't know how much time will be there. I will just take you through a kind of ADPP's efforts to protect the people living with HIV/AIDS in Mozambique from tuberculosis through some very basic community-based interventions. Now, I am not going through this slide in details because all of us know that Mozambique is high TB and high HIV burden country, especially in terms of HIV. There is a recent study of Ministry of Health shows that there is a marginal increase in HIV prevalence. And in TB, we have seen it is already, the TB incidence is more than 500. And mortality rates, especially excluding TB and HIV co-infection, is also quite high. In terms of TB HIV co-infection, again, the incidence mortality quite high. And if you see, especially in Mozambique, the TB HIV co-infection or HIV prevalence, TB, everything is, it is basically it is more concentrated into the southern part of Mozambique, and then the next concentration is in the middle part of Mozambique, and then the least prevalence is at the northern part of Mozambique. So we can see this kind of geographical distribution of the epidemic in Mozambique. So ADPP Mozambique, ADPP is a Mozambican non-government organization. It was founded in 1982, and it is basically aiming at address the root causes of poverty through promotion of social and economic development. ADPP targets mostly the most disadvantaged social groups: women, girls, children, youth, vulnerable, and who don't have much access to the health services. And ADPP is also a member and co-founder of the Federation Humana, People to People, an international federation of 32 development organizations working in 43 countries. And if you see the ADPP has many projects in health, in agriculture, in education, in livelihood. But here I just plotted the ADPP's health and TB projects, and if you see, it is mostly concentrated at the southern part of the country, and a few projects are there also in the northern part. Now I will come to the key project. We call it Project Hope, which is being implemented in two areas, 8 districts of Maputo province and 5 districts of Maputo city, where the adult HIV prevalence in Maputo province is 23%, and in Maputo city it is 17%. And this project is implemented mostly by the community councillors. Their total number of community councillors is 141. They're mostly trained by our principal recipients of this project, and they're mostly supervised by 10 supervisors. And this project is doing a lot of field-based community-level activities like home-based counseling and testing, home-based education, initiation of antiretroviral treatment to the newly infected cases, TB screening, retrieval of lost to follow-up cases. And this project also uses an IT-based mobile application to track patients both in the community and in the health facilities. So basically the flow of activities like this, that the HIV index cases, the lists are basically, they're collected from the health facilities, and then those households are visited by the community councillors. They offer counseling and testing to the household members, mostly the children, spouses or recognized partners of the index cases, and the sexually active adult members of that family, and also the sexual partners of HIV index cases who are outside the family. And the new persons who are detected with HIV infection, they are initiated on ART or other treatment at the health facility, and they are also screened for tuberculosis. And if they are TB positive, they are provided treatment adherence services, and till successful TB treatment completion. On the other hand, the PLHIV, they are also continuously they are provided the treatment adherence services, and the CD4 count were tested as a follow-up. So this entire adherence process has been tracked by a mobile technology-based community care and support system. So I will just cover the TB screening part. So what exactly a community counselor he do as far as TB screening is concerned? So he perform the symptomatic screening of the index HIV case, the infected or other household members. The presumptive cases are referred to the local health facilities for TB testing, and they are also followed up time to time to know the test results. If they are positive, they are provided treatment adherence education, follow-up, test support, and family education. And at the same time, this project it developed a kind of small support groups, community and family-oriented support groups. We call them DO and TRIO. DO is a combination of the patient and one of the family members, and TRIO is the combination of patient and one of the family members and one of the accepted community members. So these groups are provided very basic education on TB, HIV, and they will be responsible. They will be given the responsibility to look after the patient, ensure treatment adherence, follow-up visits, and time to time these groups are also visited by the community counselors for the necessary follow-up and mentoring. And the entire treatment outcome is documented after the completion of the treatment and reported to the project. This is how the mobile technology, it is a very simple schematic diagram to tell you how this particular mobile technology works and helping the community counselors to track the TB patients. So the counselors, when they make the referral of a presumptive case to the health facility, then after that referral actually gives an alert to the case manager of the health facility through the mobile apps about the referral. And the referred case, if the referred case reaches the health facility and get himself or herself tested, and if the test result is positive, the case manager of the facility will give an information telephonically to the counselor that the patient is negative. If the patient is positive for TB, then the case manager alerts the counselor through that mobile apps through an alert. And when the counselor receives the alert, the counselor again goes to the patient's household and brings the patient for treatment initiation. And the mobile apps also alerts the counselor that when the patient is due for his follow-up visits. And accordingly, the patient was also brought to the health facility for follow-up visits. And at the same time, the counselors creates the DO or TRIO at the family level or community level and keeps on providing the treatment adherence support. This is the results of it is almost more than a 1 year results, which I am not going to tell you line by line, but it shows that successful completion rate of tuberculosis is quite high, especially it is 87% in Maputo province, and it is almost 90% in Maputo city. So what is the protection package from TB? So we have seen that this is the service which, starting with the HIV counseling and testing of the household members of the index HIV case, and whoever becoming positive, they are initiated on ART at the health facility, and they are providing continuous treatment adherence till vital suppression, and they are also screened for tuberculosis, and if their tuberculosis positive, they are initiated on treatment and they are provided the support, necessary community-based, family-based support till successful completion of treatment. I'm not saying about conclusion, we are saying this is our learning, what we have learned from this project, that tracking the index HIV case and their household members through a home-based testing is a very strategic way to reach the larger number of HIV-infected people in a high prevalence settings. But it is very challenging to reach the sexual partners of the index HIV cases due to larger stigma and lack of disclosure. So the most of the people we tested their household members, not the sexual partners. The approach can be well integrated with the TB screening and the treatment support services. And providing support, this is the most important learning for us, that providing support to TB treatment with a mobile apps based backup and linking the patient with family and community support groups is highly useful to achieve the desired results. That means mobile apps plus human touch is very important. So that human touch, by involving the family members, by involving the community members, combining together gives us a much better result. Thank you so much. We are grateful to Ministry of Health Mozambique, National HIV and TB Program Managers of Mozambique, our partners, the principal recipients, Ariel Glazer, ECPAP, CCS, JAPIGO, CDC, FHI 360, USAID, Global Fund. Thank you so much.